Very much for inviting me to this talk. I fear that the cutoff for the talk is set very high. So we had some realistic views today, and I think I have to add some more. Let me come back what we have in pulmonary vasculopathy, and I think that's what we should call it, in patients with pulmonary atresia, because I'm not going to talk today about the multiple ways to treat pulmonary arterial hypertension in the setting of shunt, classical shunt, but we have to face the anatomy, and we have heard that in several talks before. Just let me summarize. We deal with different types of arteries, and we deal with different types of anastomosis to the lung. So we have the bronchial arterial system, we have direct aortic branches, and we have indirect aortic branches that all have their specific anastomosis, the bronchial artery to the interpulmonary anastomosis, and the direct aortic branch most likely to the hilus, and the indirect aortic branch to the extrapulmonary anastomosis on the periphery. And this is known already, well, more than 30 years. And let me come back to what that means to us. We have, in pulmonary atresia, we have not only a disease of lung vessels, but we have a disease of lung. So the intra-arterial arteries are smaller, and this is a key paper which I found. We have increased muscularity of pulmonary arteries only in patients that are shunted. And we have obstructive lesions and intimal hyperplasia in some of these patients with shunts. And all in all, the alveolar number is decreased. We have less lung. And the alveolar size is increased, which seems a paradox, but you have, and in effect, you have less alveoli, and the size of the alveolus is bigger. So the disease also implicates a change in lung anatomy. And my previous teacher, Glenys Harworth, whom I had the pleasure to work in 1994 in London, she did a wonderful series summarizing some of these patients and giving the details on anatomy on the interpulmonary arteries, reflecting the differences in external diameter versus the arterial medial thickness. And where you have here the normal anatomy, like here, you find that all these arteries, also in the interparenchymal intersegmental part, they are smaller than in the normal. They are smaller. If they have collaterals, they have stenosis, and we know that in several talks before. A minority of these patients show medial hypertrophy, and that's one of the things we'd like to treat with our classical pulmonary antihypertensive medication. And the intersegmental pulmonary arteries, they fail to grow. So we have a problem of growth. And what does that mean to the lung? You see here the conception to 40 weeks, and just to go through with that, already at the 6 weeks, we have lung buds appear with lobar structure, branching driven by the mesenchyme, but the vascular development, we have then the pulmonary arteries, they bud off, and then that goes straight forward through the whole development until we have, at the end, at 40 weeks, we have a mature system, we have alveolar susceptation, the surfactant system works, and the formation of true alveoli. But the damage has been done earlier. The damage has been done here, and it reflects to all parts of the lung. So it's not a wonder that almost 30 years later, we got sort of pulmonary hypertension included in international classifications of pulmonary vascular disease, also concerning congenital heart disease. And look what has been done in the last update in Nice in 2013. We have now a term which is called segmental pulmonary hypertension. That means we have to face that some parts of the lung are hypoplastic and others have classical findings of pulmonary arterial hypertension. So back to the papers of Frank Hanley with his extreme large experience and a lot of patients, and he published a wonderful paper in October 2014 summarizing the genetical differences that we see in bronchial arteries, in pulmonary arteries, and with respect to the mRNA expression profiles. So he took samples from 21 patients, and he did microarray analysis, and he took probes from the aorta, he took MAPCAs, he took pulmonary artery. And you see the distribution, if you compare MAPCA versus the pulmonary atresia, pulmonary artery of a fallow-type pulmonary atresia, if you compare the MAPCA versus the aorta, or the aorta versus the pulmonary artery, you all get different distributions, in the basic genetic expression concerning molecular function, biological processes, and cellular development. And these are important. And again, you will understand that no single drug can really address all these differences. So we have a wonderful talk by Professor Gittenberger de Groot, and her group has a wonderful model of a mutant mouse that we can produce mice with MAPCAS. And you see again what happens here in the wild type here. And you see here, you have in embryonic days, what happens with your lung volume in compared to the VEGF deficient mouse that is completely reduced. So this is a wonderful way which lead us in the future also to address these developments with terms of genetics, and also then be able to design special therapies concerned for these different vascular structures. And what do we want in pulmonary atresia with VSD in terms of medical therapy? Yes, we want vasodilation, and of course we have oxygen, high PA, bradykinin, atrial natriuretic peptide, prostacyclin, nitric oxide, and then we have adrenergic innervation that keeps the vessel small, and so forth. But what do we want? We want this here. We want big vessels, as Mark said. We want vessels that are dilated, that lower the pulmonary artery pressure, that lower the right ventricular pressure. That's only one part. We have substances that are able to address the endothelin pathway, the endothelin receptor antagonists. We have substances that address the nitric oxide pathway, even now a direct stimulation of soluble guanylate cyclase. And we have the substances that address the prostacyclin pathway. What are these substances worth in pulmonary atresia with VSD? And I'm not so positive as my colleague Michael Hofbeck with respect to the studies we have that are out, the data that are out on treatment of patients with pulmonary atresia with VSD with all these pulmonary antihypertensive substances. The only thing I want to show you is a series of about pulmonary atresia patients. So we have here 5 of these 14 patients that were treated with bosentan, and we see some improvement in functional class, but these are data that are best observational, and at the end we don't have a good study to really demonstrate a true benefit over a longer time. This is my opinion. So what do we want second? Of course we want growth. Yes, that's what we want. We want this thing to grow, and this is done in Berlin. In my early days in the Pathology Institute, we did angiographies of these patients with heart defects, and that is a normal neonate that died from sepsis, and that is what we want. We want growth. So can we get growth? And yes, we know this for 40 years that we can get growth. Mark Willig has demonstrated it very nicely. You see one of the original papers of Kirklin, and in this old angio, but still good angio, you see that if you put a shunt on it, then it will grow. But you see also that you get a stenosis on some sort of vessels. In other words, you have vessels that like to grow and others that do not like to grow, and that's the problem. So have we gone further with that? And a little bit, but not really. I mean, we know, and Dr. Brees really nicely demonstrated the effect of vascular endothelial growth factor on vascular growth. We see here lung buds really communicating with alveolar structures in this nice paper. So we know that vascular endothelial growth factor has something to do with it. But in the same way, we know from very good paper from Norbert Völkel that different splicing from the same pre-mRNA will lead to totally different genetic products, and some of them are anti-angiogenic even, and some of them are pro-angiogenic. So at the end, we know very little about these things. And we all do our calculations, yes? I mean, we calculated something will grow, yeah? And as Professor Fischer yesterday stated, we cannot even explain gravitational force. So we should be realistic at this point. And if we want this vessel to be up there, it will not say that we put everything with a shunt on it, we treat it, that we will do it. We just do not know how it works. And there, and I promise to save time, I come to the summary. Pulmonary atresia with VSD may be segmentally and may be present with, while other parts of the lung are hypoplastic, yes. And the pulmonary artery, the map the aorta, in these patients with pulmonary atresia and VS, show different gene expression on microarray analysis. So these different structural types of blood supply to the lung do not uniformly respond to our classical substances, so they should be used with caution. And at the end, pulmonary angiogenesis and factors influencing this angiogenesis are at best incompletely understood. Thank you very much.